In case you haven't heard, America's medical industry is pretty effed, but it doesn't have to be. Welcome to wRight to the Root. I'm your host, Stephanie Wright. Join us as we dig down to the root of the insurance industry's most complex problems and how we might be able to turn it all around. So today on wRight to the Root, I have Dr. Ed Weisbart of Missouri. He is a family practice doctor and a healthcare advocate. And so I'd really love for you to tell our audience a bit more about yourself.
Sure. Yeah. Nice to see you. Thanks for all the work you're doing. I'm a retired family medicine physician. I practiced for 20 years in Chicago at Rush Medical Center. I moved to St. Louis, actually, where I live now, to be chief medical officer at Express Scripts, a pharmacy benefit management company, which I retired from in 2010. Shortly after moving here, I started volunteering at one of the safety net clinics around here, and I stopped doing that about 3 years ago or so. So now I'm fully retired from anything like that. And then, shortly after retiring, I started thinking, gee, I need to really look at what we can do to really change the healthcare system. And I looked around to see who was working on it, and I discovered this group that I'd known about, that I was distantly involved with for decades, but I got more involved with around 2012, called Physicians for a National Health Program, or PNHP, Physicians for a National Health Program. And I went to my first meeting over there around 2012, and I went, oh my gosh, there's like a lot of us who really think we know we can change the system and make things better. And to be honest, I've never really cared too much about system change. What I care about are all my patients that I've seen struggling over the years with all sorts of horrible things that we've all seen that were caused or made worse by system problems. And I just gradually became to realize that I can fight for my patients in the exam room, but if there was a way to fight for my patients outside of the exam room that could really be more influential, I thought that was really an important thing to engage with. So that's how I spend most of my time for the last more than a decade now, is trying to really fix the American healthcare system, or advocate, join with the people that are working on that.
Yeah, which is a huge undertaking. There's so many different misconceptions. And I try to tell people all the time, I don't want to make this podcast on a political standpoint, but this is just such a political hot point. People are so worried about increased taxes, but they don't think about how much, well, what are you paying every month for all your premiums? And don't get me wrong, I don't think that there's a perfect system out there, but when we have an access to care issue, whether it be a $10 copayment, a $35 copayment, or $6,500 for a deductible that has to be met, that is a barrier of care. And it's unfortunate, and we have to find some sort of solution. And so traveling around the world and discussing different health systems, what is good and bad, I've gotten to hear quite a few interesting ones along the way. What are some of the different advancements that you guys have made? Is there lobbying that is going on in regards to having a single payer system?
Oh, there's a lot going on. Our organization started advocating for single payer 1987 or something like that. We sketched out a plan, sketched out a program design, pulls from some of the best things in the world. But frankly, from 1987 until maybe 5 years ago or so, our mission seemed to be research and education. Better describe the program, better describe the problems that we have, better describe the solutions. And frankly, until Bernie Sanders ran for president some years ago, most people hadn't even really heard of Medicare for All or single payer, or if they didn't begin to understand it. So that mission of, let's just spell out the plan, let's spell out how bad things are, let's focus there, sort of research and education. That was the right mission all that time. But what we've realized the last few years is that's no longer an adequate approach. Teddy Roosevelt campaigned on national health insurance in 1912.
Really?
1912, yes, really. He lost that election. He lost that election. But no, Teddy Roosevelt ran on this. We really shouldn't keep doing what Teddy Roosevelt tried to do. We should be more strategic. And so that's really where we've been focusing on, is more of a strategy. So we've been focusing on education and research. We're still doing that as an organization. That's still table stakes, because there's a lot that needs to be done on that, but more of a strategic plan, looking at What are the barriers to this? What are the compelling strengths about this? What are the arguments that really resonate with most people? How do you reconcile what we're talking about with what really are the kitchen table issues that we're all dealing with every day? So we've been focusing on more of a strategic plan.
Yeah, the biggest complaint I hear as far as nobody wants their taxes to go up, and I already mentioned that part, but nobody wants their healthcare dictated by the government either. And I can understand that and to an extent as well too. But nonetheless, what we have going on right now in this privatized insurance is not working. When you have so many people that are literally dying because they couldn't afford the preventative medicine, or they can't afford to even go to the doctor to get something looked at in fear. And so as we look at these things and the cost that it is for an average American, what would that look like in a single payer system?
It would be so much easier, so much simpler.
Yeah.
It's just getting sick is terrifying and obviously dangerous. Wanting to stay healthy is difficult and sometimes expensive. And for either of those, trying to stay healthy and get preventive care, or if you get sick and you want to get your whatever illness you're dealing with treated, you have to navigate the whole system on its own, and finding the doctor you want to see and all that's all complicated enough. And then on top of that, once you've done that, then to figure out, is your insurance going to pay for it? How much are they going to pay? Where do they want me to go? Because they think they know more than we do about our own health care.
Yes.
I have to get their permission. It's just, I'll give you just an example, just thinking of an example when you brought up what's it like. My wife, and I have her permission to tell you this story. My
Okay.
wife, a few months ago, needed to get a CAT scan of her chest, a high resolution CT. And I am not her doctor. I'm not that crazy, but I'm the logistics person for the family. So when she needed this CT, when her doctor said she needed a CT, I called up radiology. And the first thing radiology asked me, they didn't want to know her name. They didn't want to know anything about her diagnosis or symptoms. They wanted to know what insurance we had.
Yes.
And I told them we have traditional Medicare, Part A and B. We have Medigap, Plan G. And then they said, great. They said the next question, again, before they asked me her name, was, what time tomorrow would you like to come in? I went, yes, America. That's how it should work. And so we set that up. And then when we got through, I asked the clerk who was helping me, I said, so why did you ask me about the insurance? If I'd given you a different answer, what would that have done? And she said, well, if you had had Medicare Advantage or really anything other than traditional Medicare, I would have told you that we will call you back in a week or two because we have to get permission. We have to get permission, prior approval. And for our circumstance, the CT was fine, she's fine. But for our circumstance, that would have been terrifying because nobody goes to get a CT of their chest just for giggles and
Yeah.
fun. You go because your doctor told you something's really wrong and we
Yeah.
really need to. So you're scared. So for us, it would have been just terrifying for the 2 weeks to wait. Wouldn't have mattered. She was fine, good outcome. But for some people, having to wait a week or two
Yeah.
for that's life and death. A couple weeks delay on staging and getting to treatment for your cancer, that can get you to the next stage, which can
Yeah.
mean you're not a surgical candidate or your outcome, your chances of living will be smaller. So for us, it was just good outcome, happy. It would have been terrifying, but for some
Yeah.
people, and why is that? Why do they do that? They do that for one reason, their greed.
Yeah.
Their greed, oblivious to whether it will hurt people, that's just like decimal dust. They don't care about that. And if you call
Yeah.
them to complain, you're making us angry, you're compromising our health outcomes, they'll say, great, because you're becoming expensive. Go find another insurance, buddy.
Yeah.
It's just all wrong. So for what it would look like, it would mean nobody getting in the way. You going to your physician, whichever doctor you want, whenever you can get in,
Yeah.
and doing what they say that you want to do without some insurance bureaucrats saying, not so fast, buddy. We
Yeah.
gotta get in the way because you're costing too much.
It's, yeah, the bureaucrat and then even the auto adjudicated processes that go out there. And it's AI that's approving, denying care. And for myself, similarly, as an Ashkenazi Jewish woman, high rate of breast cancer in my family, in 2021, they found a mass. It was suspicious. We did a biopsy on it. It was benign, but they wanted to put in a metal marker on there because they said, we really have to watch it. It's got some precancer indicators. I thought, remove them. Why are we waiting when my mother had breast cancer before the age of 40? Like this just goes on and on. And so that was denied. And because I know how to push and advocate against the system, and I got MRIs in the rotation, 18 months later, I had cancer on the left breast. It was so far in the axillary tissue that even the oncologist had said I would have probably had it for a couple of years. And so before it was caught on a mammogram, and even backing into the mammogram aspect of it, it's I have to sign off on a piece of paper that says I will pay the difference for my 3D mammogram because my insurance probably won't. And when we're talking about how dense women's breasts are, you're basically making the traditional mammogram obsolete because everybody's got some dense breasts. And so it was mind-boggling to me. But then you find out you have cancer, and as you're talking about that waiting period, so I have to go in for my appointment, and I waited like a week for it to find out more information. Then I have to go wait for the approvals so that my plastic surgeon, reconstruction, they can get it. The breast surgeon that's removing all the cancer can get all that stuff. And that is a really painful wait. And I literally lost sleep. When we have to go ahead and navigate these systems ourselves, we're just damaging our mental health because we're not going in. We're afraid of being denied care. We're afraid of being gaslighted over it. We're afraid of if we're going to end up in medical debt. It's time for America to wake up. And like I said before, I don't think that there's a perfect system out there. We have a serious problem here in America, and the greed for private equity that has tapped into these larger systems. They're creating rules that are beneficial for them that also tie into how they can work the system for the private insurance company. So how can they make more money off from the rules that these arbitrary rules that insurance companies make on top of it? And it's bizarre to me, the loops that people have to jump through. Even back into December this past year, I had a bladder surgery, and that evening I was really uncomfortable. And I know as a healthcare professional, you can get on maps, you can see any of the prescriptions anybody has had. And so I called to say, I just want something, one thing to let me sleep tonight. That's it. It's the same health system that you could see in my chart that I had surgery that morning, but yet they told me I had to go to the ER if I was in pain. And I go, $250 thing, so guess what? I just was uncomfortable really badly through the night in a lot of discomfort. But that's the system that they want, right? There's no money in that to just go ahead and call something in, even though you see these things. Let's find more and more opportunities that we can take from the American people. And I need the American people to realize, look at how much you're already spending right now. What if those massive amounts of premiums that we're spending is going towards something that is accessible, that we don't have these other large investments on it? And that part is mind-boggling. And I go to these other countries with universal health, and it's the general consensus is they're happy. There are some countries that the doctors, they went into healthcare to help patients, not to become rich. And you see it generalized, everybody's complacent with it. They're okay. I don't know how this topic has become so politicized the way that it has. Bernie Sanders, as you brought him up, Senator Sanders has been talking about this since the 80s, right? How far are we along with really changing the tide? I realize our current administration is probably setting us back some, but what are your thoughts?
And first, I want to make it clear that we're not in this because we stumbled our way here. We're here because the people that can rapaciously profit off of us want it this way. We're here because they make us here. They put us here. And until we step up and take back our democracy, it's a heavy slog. So we're talking about healthcare, and I'm obviously focused on healthcare. You're obviously focused on healthcare, but somebody out there is probably having the exact same blog discussion about any of the million other issues that are all needing to change, and that only can change if we rescue and repair and really rebuild our democracy. But the reason why it's so exciting to focus on that on healthcare is because there is no escaping healthcare, right? There is no,
No.
nobody gets out of this dance alive. We all
Yeah.
do. Everybody, on average, what we go to the hospital every 5 years or so. We go to the doctor 3, 4 times a year. We go to the pharmacy once a month and we take our silly pills every day or several times a day.
Yes.
Healthcare is like in our face. So, yeah, but the question you're asking is how far along are we? And I can give you a pretty good metric on this. We have just this week, no, just last week, time. Just last week, the bills that would accomplish Medicare for all, there's one in the House and there's one in the Senate, and they were reintroduced just last week, Tuesday last week. And the one in the House was reintroduced this time with more than 100 U.S. Congresspeople, U.S. representatives, more than 100 from all over the country as co-sponsors, as original co-sponsors. More than 100 U.S. representatives, and there's a parallel bill in the Senate, which the Senate's not as easy, but the Senate we had, I think, 16 senators, which I believe is the most senators that have ever signed on to the bill in the Senate. That's not passing the bill. The bill's not, but it's the point of how good those numbers are is that the movement to adopt this bill has never been more vibrant, alive,
Wow.
and hopeful. And I think what we're seeing too, more than we've ever seen before, is much stronger collaboration amongst different organizations, no longer as siloed. It was that organization and this organization, and some would talk about Medicare for all, some like mine and like National Nurses United made it a centerpiece, and then others would. But now actually there's we call it a coalescence of these organizations. There's dozens of these organizations, including mine and the ones that I mentioned, and Public Citizen and Social Security Works and Just Care. And I probably shouldn't, People's Action, I probably shouldn't mention some because there are now dozens of us that meet every 2 weeks for the last couple of years figuring out who's strong at what. My group, Physicians for a National Health Program, we are what's the first word in that name? We're physicians. So
Yeah.
PNHP brings physicians to the fight, more than 26,000 physicians from all over the country. So when one of
Wow.
the other groups wants a physician at their town hall or at one of their, we provide that. We're
Oh,
there. Our physicians led 45 congressional meetings this year on related work. So we bring that, but other groups are bringing other things. So we don't try to replicate what they do. They don't, and so we're really collaborating. So you're asking how far along are we? What's the reason for hope? The reason for hope is there's a much more strategic plan that's much more collaborative and really working together. And I'm really encouraged. But you're right, it's not going to happen the next however many days that we have left of this
yeah.
terror we're living under, and it's not going to
This terror that we're living in is
happen. Everything seems impossible 2 years before it's accomplished. And
yeah.
I think we're all the surrogate endpoints, all the intermediate markers tell me we're doing great. We're going to get there.
That is really great. So you telling me how far along we are is so exciting for me. And then in addition to that, as I'm hearing you talk about the 26,000 physicians that are there and advocating and on that ground level, and they can join these meetings. One of the things that I learned with Dr. Philippe, who's the World Medical Association president, as I talked to him and we talk about these different associations, and he said, you know, if you enter into these associations silent, that's all you're going to get. So doctors, they're going to complain that I'm part of the AMA, I'm part of the ADA or MDA, whatever it might be for the state. They don't do anything for me. And before I went into that conversation with him, I would have absolutely echoed that same thing. If I have my clients that want to ask, should I rejoin the MBA? I'm like, I don't know what they're doing. Why? But now it's one of these things of you have to be part of it. You have to be part of this movement. If you want change, you can't just join and hopefully you're going to ride on the coattails of a few people. We need power in numbers. And so it's so exciting to hear that there's that many physicians around the nation that are there and they're using their voice. It's not just a pay a membership fee and hope for the best.
No, we are
So
not that kind of an organization, although we certainly welcome the membership fees, but we are,
we got to get
that's what,
that.
that's our lifeblood. But no,
Yes.
we have a process for making sure that the piece of our strategy that we're focusing on is actually something that our chapters, we have chapters in almost every state. We want to make sure that the piece of the strategy that we think we're focusing on is actually what our chapters agree that so physicians all around the country agree, hey, wait a minute, this is the focal point. And then we come up with tools and things, and they actually adopt them quickly and do stuff. And so a good example of that is, I think, a huge major issue with healthcare in America is the privatization and the profiteering that's going on. And that's everywhere in the system. That's dialysis, that's hospice, that's medical group ownership, that's specialty, that's rate. Pick your part. And so if we decided we wanted to focus on privatization and profiteering, oh my God, that's a huge topic. And we don't have the resources to make a campaign on every piece of that. So we went through this process of meeting with our chapters and physicians all around the country and other thought leaders and decided the biggest threat to getting to single payer, to getting to Medicare for all, is the destructive attack by Medicare Advantage. And so we've made that the profiteering of Medicare Advantage, the way that's destroying Medicare itself, we've made that one of our key, that is actually our key focus. So our strategy is three things. Basically, number one, pass the bills that would get Medicare for all. We just talked about that. Full court press on that, and hooray. Number two, it's stop this profiteering. They're draining, we think, $140 billion a year out of the Medicare
Yeah,
resources for their own profiteering. Just we only pay them to tell us what we can't go do. We pay them to tell us who we can't go see. So that's the
yeah,
second piece, is fighting them, and we can talk more about that. And then the third piece is we have to improve traditional Medicare, because traditional Medicare, there's no limit on your out-of-pocket expenses. There's a
yeah.
copay, there's deductible, and so you have to buy Medigap if you're in traditional Medicare. A lot of people can't afford the $175 or $200 a month to buy
Yeah.
Medigap insurance, and so they are trapped financially in Medicare Advantage. They can't
Mhm.
afford the $50 extra to buy a drug benefit, so they are trapped in Medicare Advantage. That extra payment we give Medicare Advantage means that there is a maximum to how much your out of pocket can go and that there is a drug benefit. So if we actually succeed at stopping the overpayments to Medicare Advantage, we need to make sure that anybody in Medicare Advantage has a safe landing pad in an improved form of traditional Medicare. So these three campaigns are interwoven.
Yeah. There was one of your YouTubes that's at the very top that it's the Medicare disadvantage. And I'm like, yes, it is. I I think that society as well too, they look at it from Medicare, Medicaid, whatever it might be. And doctors on one hand of it, they don't like it because it's not sustainable when you're getting paid pennies on the dollar for something, right? And they don't increase with the rate of inflation on things. And now patients as well too constantly feel that pressure of everything getting denied. Part of my advocacy is getting patients to fight back as well too to those insurance companies. We have to push back. We can't accept no for an answer for something that an insurance company who's never met that patient, never looked at them, never shook their hand, doesn't even know what they look like, is dictating their care over the doctor that has an established relationship with them. In addition to that established relationship, one of the other fears is, who are they going to push me off onto that I don't know? It's so frustrating. So I think as a whole, when people look at the government hand in any sort of the insurance, they look at those significant negative aspects of it and can't blame them. It's really hard, and especially for the senior community, they don't know what to do. They're not on social media hacking everybody's tips and tricks on how you can get through the insurance company or these private equity and push for what you're supposed to, or they're just paying bills as well too as they come in, which then deters them from going back to the doctors. It's insanity. In 2023, Delta Dental, medical insurance, dental insurance, I know are two different things. I call it an annual coupon for dental benefits, but they have a big hand in some of the Medicare that's out there as well too. And when you have a company that has billions of dollars of revenue that they're making, Delta Dental of Michigan served me a cease and desist in 2023 for my work. And isn't that just telling that you want to silence somebody because it's all about money on your end? Because I'm not speaking anything other than the truth, right? And helping patients and helping my clients educate their patients so that their patients are educated in this health literacy aspect of it, the insurance literacy aspect of it, so that they can push back. That's what we have to do, is to tell people is it doesn't have to be that way. It doesn't have to be taking a denial and just dealing with it.
Yeah.
But that is, what are some different ways that the organizations that you're part of or that you work and partner with are trying to educate the general public as well?
Yeah. So it's interesting you bringing up the dentistry piece. My father was a dentist in Chicago, and he passed away several years ago. But I had reasons to look at his old dental office, and it's actually still there. He was a one-off. It was him, and there was, I think, a podiatrist in the same suite. But the office now has one of the large corporate chains running it.
Yeah,
And my father had no conflicts of interest. He was just full out retail, but these chains put people under great pressure. But
absolutely.
yeah, so what can patients do? I think the most important thing for patients, a patient who's actually trying to make a decision about this for themselves about their insurance, if they're in the Medicare program, should know about, they're called the state health insurance programs, the SHIPs, SHIP. So most patients turn to brokers, insurance brokers, and they have incredibly conflicted financial interests. The insurance brokers make their money. They actually have from pushing people into Medicare Advantage. There's insurance broker information about how many hundreds of thousands of dollars a year they can make in their retirement after they've stopped working every year if they built up enough patients in Medicare Advantage. Because once they've signed you up for Medicare Advantage, they get a commission and they get a smaller but very real commission every year after that for the rest of their lives until you switch plans. So they have incredibly
Of
conflicted
course.
interests. So you should not use, there are some good ones. I know a couple actually. There are some highly ethical, but
Yep.
the final them. So what they should do is go to a SHIP, and these are all over the country. They're staffed by volunteers who sign clearly that they have no conflicts of interest. It's federally funded for the leadership in each state, but the vast majority of them, the people you would see there are volunteers without any conflicts of interest who just want to give you the best advice. Or call
That is
1-800
fantastic.
Medicare. That's an incredibly good phone number until I don't know what they're going to do to it. I don't, but it's an incredible, at the moment, it's still an incredibly good phone number. Please,
Yeah,
Dr.
yeah.
Oz,
Who knows
don't
going
mess
to
with
answer
that.
the phone calls in the future?
Yeah, I don't know.
Elon
You
Musk
brought up
might
the
get a
idea,
hand in
yeah.
that.
You brought up the idea that physicians are worried that they wouldn't make enough money under a Medicare for All program because of the way that's working sometimes nowadays. What I think folks need to understand is that there have been at least 8 different large analyses of whether we can afford as a country to do Medicare for All. There was one from the Rand Institute, there was one funded by the Koch brothers, one by the Urban Institute, and then 5 done a couple years ago from the Congressional Budget Office. So 8 large studies, each of which concluded that actually the country can get rid of copays and deductibles, can have everybody in the country covered, go to any doctor or hospital you want, and it would cost the same or less as what we're doing today. And the reason I'm bringing that up is because all 8 of those studies modeled out an increase in how much money physicians are paid. And
We've
that
done
doesn't even include the fact that then you wouldn't have to spend all the money that you spend today interfacing with the insurance industry.
it.
The average
Yeah,
doctor spends about $100,000 interfacing with the insurance industry in the United States
no doubt.
and about $25,000 in Canada. So increase the payment overall to physicians and decrease their office overhead.
Yeah.
Physicians don't
And
really need to worry about this.
And getting back to patient care, we have this third person that's constantly in between it, even with the Medicare aspect of it. So you have your doctor, now you're sending it off to, like, here in Michigan, we have Priority Health. And then we have Priority Health is the one that's administering the benefits for Medicare as well, too. And so it's just this, everybody's got to make a profit in between, right? Like, why cut out the middleman? It's absolutely ridiculous. And one of the countries I visited in Iceland, and talking to the doctors there, they're very happy, right? They're living great, comfortable lives. One of the distinctions that I had discussed in regards to it is even how much they're paying for their education is significantly less. So now we have these doctors that are graduating, they don't have $500,000 in debt as well, too. So even though their reimbursements are just, they're mediocre, they're sufficient at best, they're happy, they're not drowning in debt. And trying to put that comparison out there for people to see in doctors is to say they don't have to deal with the denials. There can be, one of the doctors that brought up just this wild case, because I asked her how many denials she had, and this was a dentist as well, too, and she's just explaining a some services that I'd never even heard of in my 20 years in dentistry, which is, oh, and then we just wrote a letter and it got paid for. This is the way it should be. There's going to be people that abuse the system, because there's people that are abusing the system right now. There's private equity abusing the system right now, because as I was explaining to you about my surgery in December, right? No, let's get your $250 deductible to come to the emergency room. I honestly, no, one Valium, just put me to sleep tonight. That's it. And if it was going to carry on, I would have been in. And the in-between middleman that's profiting just an insane amount, the private equity hospital organizations who, here in West Michigan, Corewell Health owns their own insurance company, Priority Health. They sell that insurance to their employees at an absurd amount. When you have a single person that's still paying $400 or $500 a month or every other week, whatever it might be, like, you own the insurance company. How is this not a conflict of interest? This is obviously something that goes on all across the nation, but what's your experience with the hospital organizations, private equity owning their own insurance companies?
Yeah, it shouldn't be, this should be all illegal, and yet it's
Yes.
not. I just read about United made $34 billion last year, and that wasn't enough, so their stock price plummeted because 34 billion wasn't enough. And if you do the math, there's only 340 million Americans. So
Yeah.
34 billion is equivalent to a $100 a year tax on all of us. And then that's just United. That was just their Medicare Advantage business.
Yeah.
I mean, so we are paying for this today. There's no printing money machine. Who pays?
Yeah.
Where does that money? Where does private equity? Where do they get this money? It's from all of us. You
Yes.
brought up the idea that physicians in Iceland only have to pay the $200 to $400 registration fee. I heard the podcast. That was pretty cool.
Yes. Yeah.
But here, people are coming out of school with $300,000 to $400,000 of debt. Where does that money come from? Why should patients care
Yeah.
that wealthy physicians are generally more wealthy than the average population? So when patients hear that physicians are coming out of school in debt, why should they care about that? Because you're the one paying for that
Yes.
debt. That's where the money comes from. The reason it costs so much more to get to a doctor visit, the reason the insurance is expensive, in part, is so that the fee schedule that physicians are paid is high enough to pay back the debt from
Yes.
school. So it's
Thank you.
eventually it's coming out of us through 6 different layers of hands to pay for medical school or nursing school
Yeah.
or pharmacy school or dental school. So everybody takes a piece of that. So it would make so much more sense to stop that and do like they do in Iceland and
Yeah.
say you got to pay to sign up, I guess, a registration fee. No, then school, these professional schools that are filling a public need, it would be, we don't want those schools to go away. We need them. We want them. So let's stop charging 3 times as much and bankrupting everybody. Let's make
Yes.
those things available to anybody. And then you can get a more diverse population of physicians and dentists, which really helps health
It's
outcomes.
very
Um,
important.
yeah, and
There
we
has
have to
to
fix
be,
this.
yeah. This
Um,
obviously it's just this complete system problem. And just like the name of right to the root, like there's so many roots and so many tentacles of problems that we have to overcome here as far as it goes. Because if we're looking at changes in this entire system, it is all right. So we get something that's passed or accepted. Then we go on and okay, how's that education going to be paid for then? How is all these different things? How are these larger universities going to go ahead and get their $500,000 in education? It's doctors going into school for an extended period of time. That's payment enough, I think, mentally to be able to do that and have a higher income, but it doesn't have to be in excessivity because they're trying to pay off their debt or the cost of owning a practice, which the debt from education has rose. I think it was 88%. I had looked at it for in dentistry specifically in the last 15 years. That's crazy. And when we have the idea that still, again, we look at Americans and they can't grasp that you're already paying absolutely over the top right now. It's not like we're going to go in addition to that, you're going to see your taxes, right? It's going to be the funds are diverted in different ways as well, too. And having that access to care, it's as I talked with Dr. Lindbergh in regards to just a comprehensive prevention, right? If we can get people into the doctor's office without any sort of barrier, you don't have to pay because $10 is a stinking barrier to some, right? they don't have to worry about that they're going to go into medical debt because there's that fear, like you said, of going in. We have so much work to do, and it gives me so much hope that you're telling me that we're on the cusp of being there. But what happens to these larger education facilities, the University of Michigan or anything else like that? How does that money and income for their education work?
Yeah, it would be so much easier for them. They don't want to have to manage all this stuff. The education should be publicly funded, and that I think that's not written into the legislation that we're proposing, but it would be a logical consequence of that because
Yeah.
you would finally have one cohesive system that manages all of the cash flow for all of us and then
Yeah.
steps aside and lets us manage the medical practice. But you would finally have that. And so they would have to build the fee schedule that would make it possible to pay back the student loans in the schools. And so you would have, so under a Medicare for All program, you would have a fundamentally built-in business imperative to pull that out of there, to have it be something that is paid for more sensibly. Pay for the school. So it's an inherent consequence of this,
Okay.
a really good consequence of it.
Which is great to know that connection that's there. I knew there had to have been, something that obviously all works together within that. And we see some of these different colleges. I mean, there's in Kalamazoo here in Michigan, they have the Kalamazoo Promise. And so everybody gets an education in Kalamazoo, right? A college education. And that's a huge deal. So it's happening, and tax dollars are already being utilized in some smaller communities that are really getting it right. And even within Kalamazoo, as soon as they started the educational standpoint, Kalamazoo is just elevated as a whole. I'm 41 years old. Back in the day, if we thought about going to Kalamazoo, we're like, ooh, that's a rough area. And it's not that way anymore. You have higher education that's happening there. Everybody has a fair chance. And you have more rural populations as well too. So we're pulling into that diversity of different professionals, whether it be healthcare or financial or any other services. There's diversity that's coming in, which is so important because it shouldn't be just the rich kids, right? The fortunate kids that have some sort of financial opportunities to go to college. There was a, gosh darn it, and I can't recall the specifics about it, that was introduced recently that was not going to be able to have the student loans. Gosh darn it. I'm drawing blanks on it. It actually just came across social media. So I just look at our current administration is basically what I'm getting at. And it's like, you're giving me hope, but at the same time, it's again too, how many years do we have? Are we gonna be able to truly make change with people that are pushing back completely on allowing education for all, allowing healthcare for all?
I
It's
remember every time we've gone through one of these social changes, it's literally always seemed impossible. I alluded to that, but 2 years before the change happened, the Clean Air Act, the Americans with Disability, you could pick your pick. Voting rights, the rights for women to vote. Take your pick on a policy that some advocates were fighting for, and they fought for years and years, maybe since Teddy Roosevelt. They fought for years and years, and literally 2 years in advance of the change happening, if you would ask somebody, they'd say, yeah, I like clean air. We want to retool all those smokestacks. Yeah, Lake Erie shouldn't go on up in flames, but what else are you going to do with the waste? So we can't afford. And then a week after it's passed, it's like, what was wrong with us? My God, this was so easy. This was so easy. Don't you dare take my Obamacare. Or no,
right.
they don't mind having their Obamacare taken. Don't take my ACA away.
Oh,
But the point is, you make these changes and the benefits start to happen. And holy cow, this is better.
yeah.
Holy cow. I have Medicare and I have Medigap and I go to see my doctor and then I leave the office and there's nothing. There's no bill. There's no surprise bill. There's no nothing. I don't have to get permission. My wife's,
Ah,
we called for that CAT scan and bam, the
yeah.
next day. It's once things start to feel real to people, but we can do this.
Yeah, I need your fresh reminder. Maybe we'll do a call every week that you can tell me, like, we got this.
We got this, man. I mean, it's a big slog. It's an uphill fight, but
It is, but it's still true, as you said, just that fresh reminder to know that some of these big hills that we didn't think that we'd be able to overcome, and we still continue to. So
yes, yes.
When we look at other international models of healthcare, are there any countries in particular that your organization has looked at and tried to mirror for here in the United States?
Yeah, I think you said it correctly at the beginning that there isn't any perfect solution, but there are better and worse ones. So I think healthcare systems can be organized in every country is different, but the you can do really socialized medicine as they do in the United Kingdom, where the government actually employs the physicians and the nurses and owns the brick and mortar of the hospitals and stuff. You can do that. That's the least expensive way, actually. But that would be like the VA for everybody. And I don't
Yeah,
think that's culturally at all consistent with our free market bias that we have in the
yeah,
United States. So that's not, when we talk about Medicare for all, that is frankly not the model that that very many of us spend any time on. The model that does make the most sense is not National Health Service, where the government provides the care, just National Health Insurance. Just the insurance. Just pull the insurance out of this. And so that's how Canada does this, frankly. So in
yeah.
Canada, there are some large physician groups, but most physicians in Canada practice in small groups, solo or very small groups, because there's no business imperative to simplify the practice model and they can practice the
Yeah.
way they want to. So physicians practice in a large group if they want or looser if they want. Patients can go to any of the physicians that they want, any hospital that they want. So it's Canada actually calls their national health insurance program Medicare. We took the word Medicare from Canada. Canada didn't take it from us. So they call it national health insurance or they call it Medicare. But Canada's system is imperfect. We can do better than that. I'm a proud American. Canada's
Yeah.
had their program. Canada made their program all across the country in 1971. So we've had 50 some years to learn how we can do better than they did. But here's the really interesting thing. Before 1971, America and Canada were almost the same. Our life expectancies were almost the same. Our healthcare as a percentage of GDP was almost the same. We were on the same trajectory. So for decades before 1971, we were on the same curve, life expectancy and expense. 1971, Canada fully implemented their national health insurance. 1973, the United States passed the HMO Act and created managed care. And we created managed care in theory to lower the cost of healthcare. That was the whole point,
Yeah.
was to lower the cost of healthcare. There's been no change in our steady climb of healthcare expenses since 1973, but Canada's flattened out. So
Wow.
1973, and for decades before, we were the same. It's not that we're geographically different. It's not that we're demographically different. We were the same. And then in 1971 and 1973, a national health policy fork in the road where they did what we're proposing, national health insurance, and we did this crazy greed-centric, profit-driven managed
Yes.
care model, which I used to love, and now I see the flaws. But we did that. And what happened? They now live 4 years longer than we do. Our lives are cut 4 years short because we didn't go the way of national health insurance, and we spend twice as much. Managed care is not saving us money. This whole
Yeah.
insurance model is not saving us money. We spend double what Canada spends, and our lives are cut 4 years shorter.
Wow.
So you ask what system we should model off of. I think the Canadian is the closest to us. It's a free market system. If you think about
Yeah.
that, Canadian physicians compete against each other to make patients want to come see them. American physicians compete against each other
Yeah.
to find the most lucrative insurance contract.
It is true.
That's perverse. If I can find
Yeah.
an insurance contract that's going to pay me $10 more for a visit, I'm going to find the 100 patients that pay me $10
Yes.
less, and I'm
Yep.
going to drop that insurance to make room for 100 patients that pay me more. I'm retired,
Yeah.
so I'm first person singular isn't really real. But
That's
I compete, physicians in America compete with each other to find the most lucrative insurance
it's
contracts
true.
and occasionally fire hundreds or more of their patients because that's the business model. That
Yeah.
doesn't happen in Canada. In Canada, you go see whichever doctor you want because you think that's the right one for you. So
Yeah.
that's the model we think is the closest to
Oh,
us that we should do.
it is absolutely true. And even within myself as a practice management consultant, and primarily in dentistry, which the dental insurance aspect of is significantly different than it is healthcare. It's just still terrible, but nonetheless, I have to do that. I have to talk to my clients to say, when we have here in Michigan, one insurance company that makes up 70% of the insurance income. And for over a decade, they did not increase any reimbursements to doctors and effectively actually decreased in 2014 by 30% to for PPO doctors. I know. Yeah, that's a very shocking. It was though. And so they allowed legacy premier dentists to have this higher fee schedule, but it did not move. For 10 years, it did not increase a single penny. And so I've had to work with my clients and talking to them about different strategies to say, we've got to decrease the amount of insurance that's coming from this. We have to go ahead and find the patients that are coming from insurance companies that actually acknowledge the rate of which it costs to provide care. Because there are. But when you have one insurance company that doesn't reimburse like any of the other ones, we have to change our marketing plan. We also have to educate our patients to go, hey, bring this to your HR department. You should be upset when your dental plan does not pay for this. Go ahead and submit a complaint. And we're starting to see some of those changes now that are happening where HR departments are dropping that insurance company that isn't being fair. As you said, and you're discussing that Canada and their only competition is the doctors, it's refreshing because that's the way I so wish it was here. There's like this combination of the different ones that are going on and what it is that you have to do. Yeah. It's really exciting. I'm very excited the information that you're providing me. I learned with Dr. Philippe about how many countries are actually very similar to the United States, which I was ignorant enough to think that we were the biggest problem on this globe. Malaysia, where he's from, they have privatized insurance there as well too. And he says it's a problem. The doctors are having to do so much more administrative work. And so the more and more I'm learning about all of the different health systems that are out there, I'm really hoping that patients hear pieces of information such as what you just provided now, and it gives them hope and they can be part of that advocacy for it. And then also that aspect of it to know we're not alone. This is a global problem as well too. So yeah, I'm really excited. I cannot thank you enough for being on that podcast with me. I think that we'll probably have to circle back around because I have some visits to Canada as well too. So I'm quite excited. There's a company, it's Canada Accreditation. And so they're actually global. And so there's this accreditation within healthcare that they go, and there's these different health standards that are implemented within hospital systems. And so having that opportunity to learn from them a little bit more, and now knowing that they've got a really great model, this is going to be great. Again, thank you. And I really appreciate your time with me.
Thanks for doing this. It's really important. And I love what you're doing.
Thank you so much. Take care.